Hello, good morning, and welcome to a very special edition of our Friday research meeting. Today we are joined by our director, Professor Linda-Gail Bekker, who will be taking us on a look back at 40 years of the HIV epidemic. This is a very special retrospective that we're all very much looking forward to. So without further ado, I'd like to hand over to Director of the Desmond Tutu HIV Center, Prof. Linda-Gail Bekker.
Thank you so much, Iman, and it's my great pleasure to really register not only looking back at 40 years, but of course also looking forward to the fact that on Thursday we will be celebrating yet another World AIDS Day. And this year, the tagline for World AIDS Day is Equalize. And I hope that during this retrospective, we will also dwell on why the term equalize is just so critical now, today, in 2022. But in the last 40 years, this virus, the human immunodeficiency virus, has infected more than 84 million individuals and caused the early demise of 40 million people worldwide. And in 2021, we saw yet again another 1.5 million new infections, amounting to almost 5,000 infections every day, people facing a lifelong and incurable infection as a result of this. Why has HIV/AIDS as an epidemic lasted so long? Well, there are a number of reasons, some of which are its asymptomatic spread, its long incubation with the delayed identification allowing transmission before individuals are found, the journey we've had towards effective, universal, rapid, and sustained treatment has taken some time, and primary prevention hasn't been easy, acceptable, nor taken to scale. We have no cure, we have no vaccine, and of course we've been dogged by AIDS denialism, politics and ideology, funding constraints, and throughout stigma and discrimination. So today I will try to think about the last 40 years in terms of these 6 topics: the science, the treatment, the prevention, the role community has played, politics and funding, and of course then the way forward. But in these 4 decades, we have despaired, we have hoped, throughout we have persevered. And the question is, are we near the end of AIDS? But let's go back to the beginning. And our story starts all the way back in 1980. And here is Ken Horn, if you like, patient 0, the individual who's thought to have been identified as the first case in California who the CDC had developed a rare cancer, Kaposi's, and an unusual pneumonia. Later that year, a case series was described of 41 homosexuals, to quote, who constituted this first case series in the MMR. And then the New York Times led with a story in 1983 on their front page, and breaking all precedent here, Bobby Campbell and Bobby Hilliard being shown on the front cover of News Gay America. Ronald Reagan took another 3 years before he mentions AIDS in one of his reports. So let's start with basic science. And the timelines here are, as I've mentioned, 1981, the first AIDS cases, HIV discovered as a cause of AIDS in 83. We didn't have treatment until 1987. And to date, we don't yet have a prophylactic vaccine or a cure. The person who co-discovered HIV in 1983 and then went on to win the Nobel Prize with Luc Montagnier was, of course, Françoise Barré-Souissy. And here we hear her describe this.
So it's how after about 2 weeks in the culture, we started to detect the enzymatic activity, which was corresponding to a retrovirus.
But of course, HIV was not present before 1980. And the origin actually goes all the way back to 1959, when a man died in the Congo. In the 60s, we believe HIV too a close cousin of HIV-1, jumped to humans from monkeys in West Africa. And probably HIV arrived in the Americas late 1960s, when we know Haitians were going backwards and forwards to the Congo. December 1977, Greta Rusk, a Danish doctor who worked in the Congo, described an illness that sounded very much like, and died of it, like AIDS, and retrospectively was discovered to have, in fact, died of AIDS. So the origin of AIDS has been very well described, having originated in the chimpanzees and West Lowland gorillas. So these descriptions now very clear in terms of its origin. And then we know there has been a full evolution of HIV-1 in humans, the sort of distribution of clades or subtypes around the world, HIV-2 having been discovered in 86 in West Africa. And here you see HIV-1 with the branching of its close simian virus cousin, and HIV-2 breaking away. In our region here, clade C being the predominant clade, but we described the progression of clade B to clade C here in South Africa way back in 1999. And it wasn't too much before that actually Chris Hani, one of our leaders assassinated in 92, predicted that we were facing and could face an epidemic disaster. But sadly, it was only once many, many millions of South Africans had become infected that really any kind of action was taken. And previous President Thabo Mbeki is very much known to have been at the heart of the denialist phase and the terrible cost of the inactivity in South Africa, now leading to the fact that we are the most burdened country in the world. We know that the key cell HIV target is the CD4 T cell, a white cell that is required by HIV in order to make contact and invade the human host. And it is this depletion of CD4s that actually moves on towards the acquired immune deficiency syndrome. So we know that there's a time of huge viral replication once the virus gets on board, then CD4 and CD8 loss and an eventual viral loss of control, resulting finally in the set point and the time that it takes for the CD4 T cell depletion to happen is what is a prognosticator in terms of how long an individual can live with the virus prior to ultimate demise. And so we know the human host plays a very important role here too, in terms of whether somebody is going to be a rapid progressor or indeed an elite controller, or may, really have what the majority have, which is a chronic infection, which ultimately does go on to the acquired immune deficiency syndrome. But here are important other timelines. What have we discovered about diagnostics? Well, we know that we had antibody testing in March of 85, the Western blot in 87, point of care and rapid testing in 91, viral load testing in 93, and of course, very importantly, the ability to assess how much virus was on board in 1996, resistance testing in 89. And we've learned a lot about the risk of HIV transmission subsequently. Clearly, modes have included vertical transmission from infected woman to their unborn child, described in 81, and in hemophiliacs, where blood products were shared with individuals intravenously from people living with HIV, and that leading to the first blood product screening in low and middle income countries in the mid-80s, but already many blood donors infected, as you can see in Rwanda, and then finally the first needle exchange programs in Europe in 84. We have gone on to deepen our understanding of HIV transmission. Very important that whilst people once they are fully undetectable on treatment, are incapable of transmitting. We know that individuals who are elite controllers, who are able to keep viral load down naturally, also are at reduced risk of transmitting to others. But there may be other effects, such as STI infections, which lead to transmission. So the higher the viral load, greater the risk of transmission. Persistence and reservoirs are another concept we've come to understand. The virus, once it's infected, becomes embedded in the deepest part of the human host, making it very difficult to get rid of the virus and really being at the heart of our difficulties around cure. It does mean, though, that understanding the retroviral life cycle, we've been able to find drug targets. So we now have targets against binding site inhibitors, fusion inhibitors, reverse transcriptase inhibitors, integrase inhibitors, strand transfer inhibitors, and of course, protease inhibitors. We have also deepened even more recently our understanding of how the virus moves into the human host cell. And again, this opens other opportunities for drug targets. So let's move on that note into treatment and cure, care. And of course, with 40 years of treatment, we have definitely seen hope, development, and delivery. And here we know that AZT was first approved in 1987, DDI followed, the protease inhibitors. We then became aware of highly active antiviral therapy, combinations of drugs coming together, and then coming together in a single pill. And now most recently DTG, TLD, a single drug that really is very easy to take. And finally, now injectable antiretrovirals. So here we hear it from, if you like, the father of antiretroviral therapy directly.
So now we have more than 30 drugs that are approved by the FDA that, when used in combinations, have a striking, dramatic effect on suppressing the virus. So from 1996 until the present, we just did better and better and better with regard to drugs.
And Dr. Fauci, and huge tribute to him as he retires this year, said it beautifully. HIV therapy of old is not the therapy we have today. And we know that a 20-year-old many years ago would have had a life expectancy less than 40 years. Today, they can expect to live as long as somebody who does not live with HIV. And we know that the Lisbon patient died recently, 100 years old in 2019. Really extraordinary contributions made, although now we need to move into an era where we understand how people die with HIV and what can be done to reduce comorbidities as we think about this. So this has really been the history of treatment. You can see in the beginning, we started with this hit early, hit hard, but with drugs that were very difficult to take. We then went through a drug sparing kind of evolution, holding back before we treated individuals, and now have come full circle again to a test and start concept because our drugs are so improved. Not only has it been important to get drugs to individuals, but we've needed to get drugs across the world. And this has really also been very, very important. And expansion from the developed world into the developing world has been absolutely key and critical in the last 40 years as well. With the advent of cheaper drugs and generics, we have been able to achieve this. So you see now, by mid-2020, we had 26 million people on treatment with a clear 12.1 million AIDS-related deaths averted because of treatment. And the late David Cooper said it beautifully. The story of HIV is a modern medical miracle. From despair and tragedy, we have moved into an era of chronic treatable illness in just 30 years, as he said at the time. And it really has meant that HIV has now become a chronic illness. From being the leading cause of death globally in 1999, we've seen death rates fall around the world, not only in individuals, but in populations, such that it really has had a Lazarus effect. And here you see life expectancy really being incredibly improved from a low just after 2000. And we know that the art of the 90s, with all of their difficulties and side effects, are not the antiretrovirals of today. And here is my very wonderful friend and colleague, Yvette, who said it beautifully. Her health is her wealth, living with HIV and on art since her baby was born, taking nothing for granted, living every day positively, and able to face a bright future together. So the UNAIDS 2020 targets, we unfortunately won some aspects, didn't land all of them. We hope to get to 90. We didn't quite get there. So that means 90% of people living around the world tested, 90% of those people being on treatment, and 90% of those being virally suppressed. We in fact got to these levels then. And I do want to focus on children who so often are left behind. There are 1.7 million children living with HIV today, most of them on our subcontinent, and almost half were not on life-saving treatment in 2020. And in fact, if anything, numbers declined in that year. And when children grow into adolescence, we know they go behind on every single target, including viral suppression. And we really do want to avoid new infections in children because HIV continues to be the leading cause of death in adolescents on this continent. We've made headway. We know that 1 in 2 children died of HIV if it was transmitted to them vertically at the time of birth. We've seen incredible improvement in that regard and reduction in mortality. And we've seen reduction in infection via the vertical route, especially as we've increased coverage of antiretrovirals to women. And we really want to celebrate Botswana, who has been able to reach the elimination goals. But 1/3 of children born to mothers living with HIV were not tested. Untreated, 1 in 2 babies die of AIDS before their 2nd birthday, and a clear 150,000 children were newly infected with HIV even today, which is 4-fold more than what we had in our targets. So there's no doubt that whilst global progress has been made, it has not been uniform and universal. And there is this notion of key populations. We know who they are: young women, adolescent girls, men who have sex with men, transgender people, people who use and inject drugs, people who sell and transact sex, incarcerated people, displaced people. These people are at particular risk of HIV acquisition, yet they struggle to reach our services. So we are not there yet. We have almost 10 million people to find, start, and suppress, and it is absolutely key that we leave no one behind. Our gains have not been equal across the world. And here we particularly need to think about the Eastern Europe, Central Asia region, where today, of course, a war is raging. And even before the war, this was the one place we were actually seeing an increase in death, an increase in infections. And we have no idea where we are today in the midst of the Ukrainian war. So this is the hope. If we get people onto treatment, we get them virally suppressed and undetectable, we will then see a reduction in transmission. And this has been shown in beautiful studies, 052, Partners 1 and 2, that really even condomless sex is protected if people are undetectable. So U equals U is a very important opportunity, not only to reduce secondary infection, but also to destigmatize HIV. We know for the prevention of vertical transmission, the notion that undetectable is untransmittable has been absolutely vital for women. Women knew that if they were undetectable, their babies were safe. And this is an important concept that we now need to move throughout the population to ensure that people are able to be on treatment and be undetectable. But this requires us also to think about service delivery. And it means we move into differentiated service delivery models. So this is something that perhaps we really brought home during COVID. And throughout the 40 years, we've come to understand that we can differentiate our services and make them more available to people everywhere. So DSD, or differentiated service delivery, is the what? A person-centered approach. It simplifies and adapts HIV services across the cascade whilst reducing the burden on the health system. And we know there is a revolving door of HIV care, but we can offer people less frequent clinical visits. We can offer them to initiate outside of health facilities. We can say to them that when they disengage, they are welcome back into our services. And we can ensure that if they want to start treatment today, they have access to that. So there are now coming from our continent some amazing models, group models as well as individual models of how to offer care in a client-centered way that is truly differentiated. We now need to also be thinking how we prevent primary infection. And really here we are lagging. So we missed some major goals in 2020. And it was said then that too many countries have failed to put in place the combination of structural, behavioral, and biomedical approaches to HIV prevention, focusing on the greatest need that will then have maximum impact. So much work to be done here. And of course, if anything, COVID-19 set us back. And I've already mentioned that in Europe, the war is having a huge impact, although often, and here we have a war going on in Mozambique and other parts of sub-Saharan Africa, where again, this undermines what we're able to do in terms of protecting people against HIV infection. So the reality is we have not been able to reach everyone we need to with treatment, and so people still remain at risk of HIV acquisition. And, you know, this is absolutely key, that we understand we aren't going to treat our way out of an epidemic. We tried in 5 amazing studies here in sub-Saharan Africa to see if we could reduce infection by even going door to door. What we have come to realize is that we will not end the epidemic with treatment alone, but primary prevention is absolutely part of the recipe. And here you see 4 cities where there has been a good combination of both primary prevention and universal treatment, and we do start to see the impact of treatment and prevention. So what has been happening in prevention in the last 40 years? Well, I mentioned that needle exchange program all the way back in 84, but we had the male circumcision studies in the mid-2000s. We saw the first PrEP study in 2010. We then went on to understand treatment as prevention with 052. The FDA approved oral PrEP. And of course, the Dipivirine ring studies, and of course, Cabalé most recently as an injectable PrEP agent in population. So I'm pleased to say the prevention of the first 2 decades does not look like the prevention we have in our hands now. And we have recently undergone a prevention innovation revolution. And Françoise Barré-Suissi said it beautifully. Scientists have developed an array of effective tools which can now begin to reverse the AIDS epidemic. And this leads to choice and the fact that people can actually use prevention that is adapted to their need. But here's the reality: 1.7 million new infections in 2020, 3-fold higher than what was really hoped for. So although our toolbox is looking much better, we now have this revolution around pre-exposure prophylaxis. And it's a full decade ago that we came to understand that a single pill, oral FTDF, could prevent HIV. These results were out in 2010. We had FDA approval in 2012 and WHO guidance in 2015. We've gone on to really optimize this. Now we have on-demand FTDF. We've again brought in a new agent which reduces side effects. Descovy or FTAF can also be used in this way. And then most recently, antiretroviral vaginal rings, which means women only have to place the ring vaginally once a month to get benefit. And we've seen, although modest in the randomized controlled trial, much improved reduction in incidence in the open label studies, and leading the way to the next option, which is, of course, the injectable Cabolet. So in HPTN 083 and HPTN 084, showing in a variety of populations that this once every 2-month injectable is able to reduce HIV incidence even better than the oral PrEP agent. And here again, we can hear it directly from one of our participants.
I just feel PrEP is really helping, so I am not afraid of HIV. It has made me feel so comfortable with my partner. I just feel PrEP.
So this really does offer for us an option of choice, the prevention superheroines, as I refer to them, that we now have daily options for people who prefer that. On demand, we have vaginal rings, we have injectables, and we have a bunch of other options coming down the line. We can now begin to think about prevention as not simply harm reduction, but actually moving towards putting pleasure back into sex and saying we can talk about affirmation and well-being. We can normalize behavior and really bring HIV really into the background as we talk about human beings in a client-centered way with all of their needs met. And that again talks to prevention being tailored and client-centered. So depending on risk, depending on sexuality, depending on gender, we can say what is the best option for an individual in an accessible, layered, integrated way that takes into consideration stigma and discrimination reduction, as well as social justice, human rights, and places it all within a community structure. And here are, again, examples of how this has been done. So in California, in San Francisco, we know the combination of universal treatment and good pre-exposure prophylaxis has led to incredible reductions in mortality, but now also reductions in incidence. And probably on the Bay Area side, we will see this as one of the first cities to have a complete elimination of new infections. In British Columbia, in Vancouver, there's been a good combination of harm reduction, needle exchange, OSD, and other ways to prevent HIV in people who use and inject drugs, together with antiretrovirals, to again see a reduction in HIV incidence. We know in the Indian subcontinent, there's been a very good combination of large-scale stigma and discrimination reduction amongst sex workers, using the community structures around sex workers, making sure they are part of the equation. Again, seeing a reduction in HIV, such that now in many parts of India, sex workers have a lower incidence of HIV than the general community. So we really need to see how we can take PrEP forward and scale it up. But really, again, this has been way too slow. And there's much work to be done in this regard. We also know that prevention requires differentiated service delivery, and we can apply DSD to prevention as well. So here's the model of sero-neutral programming, where it doesn't matter whether somebody is living with HIV or not. They come into our services, we offer them care in a person-centered, attuned, engaged, and community-based way. So it really does talk about a new normal that is much of what we've learned in the last 40 years. This could not have happened without the partnership of community. So let's think about the role community has played all the way back to 1983 with the gay men's crisis, ACT UP, then moving into TUSO in Uganda, the AIDS Law Project in South Africa, then of course the Treatment Action Campaign in 1998, the famous Durban Declaration of 2000, and then finally, really the blossoming of amazing community-based structures. But I'll remind you what the stigma was 30, 40 years ago, the 4-H disease, homosexuals, hemophiliacs, heroin addicts, and Haitians. And now HIV is really the everyone disease. Activism we needed in the 80s has moved into incredible and powerful advocacy. So here you see 87, Randy Schultz's book, 1993, the docudrama, The Gay Men's Health Crisis, very important. Ryan White, an adolescent who was thrown out of his school because he lived with HIV, and then went on to tell his story in the bravest way. Already mentioned Ken Horn, and then the groups, the activist groups like ACT UP. Here, even in our part of the world, the incredible role that Treatment Action Campaign, AIDS Law Projects, and other important groups have played. And here again, I want you to hear it from one of the founding fathers of this work.
We have to speak to government when it is willing to work. We have to march when government doesn't listen. When they don't listen to our marches, we take them to court. And one thing, I don't think she said this, but maybe she did. In 12 years of TAC, we never threw a stone.
And so the activism has now become advocacy. And here you see extraordinary groups who have, just really made a mark and continue to bring information and understanding to communities at large. And this really has been part of gaining trust in treatment and the power of peers. This is one example, the Caesar Pila project, which we were involved in, and just humbly saw the power of peers here as the Caesar Pila counselors went out to help others take treatment. And we see that even today, here now in prevention, extraordinary program in Vietnam of community-run PrEP, where individuals from the community help other people take treatment powerfully. And this is all about enabling environments, keeping adolescents in school, providing economic empowerments, gender-based improvement, harm reduction services, all really in the hands of community. There's been a very important role played by our convenings, and here are the international AIDS conferences all the way back from 85, each one of them landmark in the history of the last 40 years, each one bringing something unique and important to the history that we've had. I'm going to close off now in this last chapter of policy, politics, and finance, and firstly around funding. Of course, this has been absolutely key and has played such an important role to have enough resources to be able to meet the epidemic. And you can see again some very key milestones on the funding agenda. The funding increased in 2001, but has then plateaued. We've seen more resources coming from domestic, and donor dependency has dropped. But again, as we move into a recession, it's very important we watch what happens to that funding. We've seen the beginning of important funding campaigns such as PEPFAR. Extraordinary what PEPFAR has done, and we are grateful to the taxpayers of the United States, invested nearly $100 billion in the global AIDS response. And you can see just the extraordinary impact that has had in 40 years. And then the Global Fund, 21 million people on ART, 98 million HIV tests administered, programs for key populations for prevention, and of course treatment, absolutely dependent on this very important funding source. And we know that the Global Fund receives funding from more than 80 countries, the top 5 being those that you see on the slide. But every replenishment, again, we hold our breaths to make sure that we get the funds we need to be able to do what needs to be done. Here you see how the funds are needed and in what areas and by programmatic area. And you can see now primary prevention needing exactly the same amount of resources as testing and treatment, and our region with the greatest burden needing the lion's share of those resources. So we can no longer weigh up, treatment versus prevention. It has to be treatment and prevention to ensure we do the work we do. Now, we do know that HIV has been political right from the get-go. The politics of antiretrovirals was there right from the beginning, just in terms of access to treatment, the cost of treatment, the denialism we saw, the lives that were lost because of not having access to antiretrovirals. And even beyond that, the gains have not been even. And throughout, politics have played a role because of bad policies that reflect ideology and bias rather than science. You see the most vulnerable have been deterred from accessing the services they need. David Cooper said it beautifully. We were different and we were persecuted because of that. I saw the same sort of thing in the vulnerable populations that we dealt with. They were on the edges of the community and left behind. The Archbishop described it as the new apartheid. In Eastern Europe, we know who the individuals are, people who are transacting in sex, people who use drugs. They have key barriers to services that include legal and structural barriers and social barriers and stigma and discrimination. Here is a case of Romania where finance has played a role. So Romania is one of the transitional countries. They've gone from being low to middle income. And as such, the Global Fund has withdrawn resources. And we've seen prevalence amongst people who use and inject drugs go from 3% in 2010 to 29% in 2013. So it's also very important what we do with our funding and where we put that funding. Here we see the impact of people's sexuality and their status in terms of who they have sex with, playing a role, not only in terms of legalization and discrimination, but also then in their ability to access services. And too many countries around the world continue through ideology to criminalize behaviors which set people into very vulnerable positions. So here are the political timelines. I won't go through them in detail, but critical things such as the Denver Principles, the Durban Declaration, and then, important other concepts such as TAC, taking the South African government to court, the World Declaration on HIV, very important milestones throughout the last 40 years. Yesterday, we celebrated the anniversary of Freddie Mercury's death, and celebrities too have played an absolutely important role throughout the last 40 years, from Diana, Princess of Wales, reaching out and holding hands and hugging people living with HIV, the role that Elizabeth Taylor played, and many others. Nkosi Johnson, our own Nkosi, who stood up on a stage in the height of denialism to declare that he lived with HIV. And there are many, we do not forget, who died because of the virus or because of our attitude to the virus. And here, besides Nkosi, I pay tribute to Gugu Dlamini, who was stoned to death after she publicly declared her status in Durban. So we've seen 40 years of profound social impact. And Jonathan Mann said it beautifully: when the history of AIDS and the global response is written, we need to be able to say we did not flee, we did not separate ourselves. And stigma often leads to that separation. So we know that even today, stigma is alive and well. The ability of people living with HIV to receive art in some countries is still conditional on contraceptive use. They have to be able to say they're using a contraceptive in order to get their antiretrovirals. We can reduce stigma through education, through advocacy, by having meaningful contact with individuals, and through peer contact and peer services. So there are some real ways that we can reduce stigma even in our own community. So what can we do now as we look forward? We know we've had these eras of devastation, discovery, and we've persevered throughout. Can we talk about ending AIDS? Well, we can't until we equalize. There are parts of the world where HIV is far from over. The epidemic is far from over because of social, political, and economic obstacles. And so equalize is absolutely important. So what do we need to do? Action 1, we have to stop HIV in children. 22 years later, we have unfinished work in that regard. We also have to declare we will leave no one behind, and we know who we are leaving behind at the moment, and we need to work doubly hard. We need to continue to innovate and make sure that we bring these innovations to scale to people who need them. We need to continue to look for a vaccine and a cure. Please hear it from my brother Moses, who says it better than all.
This is Moses Supercharger from Uganda, a person who has been living with HIV since 1994. There are several reasons why we want an HIV cure. First and foremost, adherence of these medications is not easy. I've taken medication to close to 30 years, but I'm telling you, every day is another story. This is Moses Super.
The world needs an HIV vaccine, and really that will, I guess, bring all the superheroes, heroines to a place where we have a full toolbox. And then lastly, action 5, we do need to see HIV within a broader global health agenda. In other words, looking forward to the long haul, to really saying, how do we bring HIV mainstream? AIDS, as Jonathan Mann said, remorselessly highlights and exposes the weaknesses, the inadequacies, the inequities of our existing health and social systems and the gaps in our knowledge. In this way, the fight against AIDS has become a key element in the broader fight for health for all. So if we are to reach an end of AIDS, we have to get back on track towards the 2030 goals. We need to recognize we live in an unequal world, and we need to pay attention to that. We require a paradigm shift from silos into integration, bring the politics and the funding along with us, and strengthen our health systems for all. I believe if we do that, we can think about the end of AIDS. So I've referenced David all the way through. We lost him just before the COVID epidemic. He said, we fought the war on drugs for access to medication. We now need to keep going. We must refuse to declare victory until AIDS is ended for all populations. Leave no one behind and equalize. Thank you very much indeed. Appreciate you all for listening, and I'm happy to take any questions or I'm sure comments from the audience. Please, if you could either put your questions in the Q&A. So I see you, Lorato. How do we deal with treatment fatigue? I'm going to see if anybody wants to respond to that, because I know we've got people in the audience who do deal with taking antivirals every single day of their lives, and they may want to comment about how we deal with fatigue. If you do want to make a comment, please put your hand up and Iman will look at you, will find you and unmute you. So that's the way to do it. Maybe I'll try Lorato in the meantime to say, oh, I see there's Yvette. Brilliant. Iman, if you'll unmute Yvette. Maybe she'll also answer Lorato's question.
All right. Thank you so much, LGB, for such a wonderful presentation and taking us back to the 4 decades, as you mentioned. I think for me, the big question, someone who is 47 years old, is do you see us getting anywhere, and you as one of our leading and our favorite scientists, do you see us getting anywhere closer to a vaccine or a cure? Because you mentioned, you gave the decades, each one a name. Do you see us calling the next decade, you know, the cure decade or the vaccine decade? And further on, just to say to Lorato, treatment fatigue, The minute it happens is for you to start talking about it and speaking to your healthcare provider about it, or getting counseling around it. I've been on treatment for more than 20 years, and the fatigue is there. The big thing is not to keep it a secret and also not to feel ashamed about it. But I'm looking to you, LGBT, to just give us some guidance and hope for the next decade. Is it going to be the cure and vaccine decade?
Thanks, Yvette. I'll tackle that. I'll also say that, you know, innovation has come to prevention. It's also come to treatment. So we do now have injectable ARVs. So that could be an option for people who are fatigued from taking a pill a day. And we hope that might be another option. The important thing is choice, right? So people don't get stuck with, I have to take this pill every day because I have no option. You could have the option perhaps of going on to injectable treatment. So that's the one. That brings us a little bit closer, if you like, to the notion of a vaccine or a cure. And I would say that the last decade, we have also learned things about this virus in a short period of time than we even knew, you know, in the 3 decades before the last decade. So that's one piece. The second piece is technology generally has moved forward in leaps and bounds. So I feel optimistic for the following reasons. Although the virus is a very stealthy, complex, difficult to, you know, manage virus in terms of finding a vaccine or indeed a cure, our technology is catching up in the most extraordinary way. And, you know, we now, for example, can say we launched the mRNA technology during COVID-19. We can apply that to HIV. Now, the beauty of the mRNA technology is you can change the insert very easily, well, relatively easily, and do short, sharp experiments to see, is this the right vaccine recipe that's going to have the right impact. So people will know it took just 9 months to get Pfizer and Moderna for COVID. That's because the mRNA technology made it very easy. We can do the same now with HIV to say, it may not be the final platform, but it allows us to do the experimentation very quickly. So I think we're going to be able to do what we would have done over many years in a much shorter period of time, which means hopefully, Yvette, yes, we can get incredible progress in the next 10 years. What about cure? We now are coming together with oncology and the cancer world to say they've got some extraordinary understanding around gene manipulation, which we can apply to HIV. So those people I listed as having been cured, and we know there are at least 4 to 5 individuals around the world who now have been documented cured. Those individuals we can learn a lot from. Now, in each of those individuals, there was gene technology that played a role. Now, I know for some people that makes you anxious, but it was all above board. It was all quite reasonable, but expensive and difficult to do. So we now have concepts that we can follow, and the big thing now is to say, can we do it in such a way that it's easier, it's scalable, it can be taken to great lengths. And I'm excited that there are people like Sharon Lewin and Steve Deeks in the world today. And they have labs of young people coming to the fore who are taking this forward. So I'm hoping that, number one, we can encourage more young scientists to step into the field because it's extraordinarily exciting at the moment. Huge, gains and progress being made. So I would like to say, I think this is the era that we may in fact see progress in this regard. I'm going to look at the questions, unless you want to ask me some of these questions, Iman, because you're reading them quicker than I am.
Sure, we have quite a few comments here, just thanking you for the presentation, highlighting maybe the first one we could have a look at is how are we doing with some of the derailings of the COVID-19 pandemic in terms of research?
Yes. So thank you for that. That's Mamelo. That is an important concept because I'm talking about how we need to reach out for the areas we've not reached yet, but we also lost ground, right? We lost some serious ground during the COVID pandemic, not only in terms of reduction in testing in HIV and TB and malaria, but we also, feel like there are individuals who've kind of gone back underground. So that needing to go up the tree, if you like, and find populations we haven't reached yet because our arms are not long enough. We now need to also climb branches we climbed before to get right up to those top parts of the tree. So if I can use that analogy, it really is important for us to go back over ground we had already, we'd already gained. So make up lost ground. But we also, I think, learned some things from COVID-19. So we learned that it's possible to do multi-month dispensing. This is a no-brainer for the world today. We learned that you can do a lot on the phone with telemedicine. So again, there were things we learned during COVID-19 that we can apply going forward. And it's important we do that very quickly. There are going to be other factors, though. We know that HIV loves poverty. It loves people being displaced. It loves people not having food. And so, because the world has been set back in that regard, also during COVID-19, we saw terrible politics again, didn't we? Saw the world move very much to the right wing again and marginalize whole populations. So there's work to be done in the socio-political arena and in general global health. So this is a time when we really do need to gird our loins and get back on the bike and make up the lost ground as quickly as possible.
Fantastic. Good to look at some of the positives that have come out of that time too. We have one more question and a couple of minutes left. So this is quite a specific one. It says in the UK, we are doing a seroprevalence study of MSM using anonymous HIV saliva samples, but in our setting in sub-Saharan Africa, we must provide the test result at the point of contact. Pancho's question here is, why does the UK continue to do anonymous saliva samples for surveys? Your thoughts?
Yeah, so thanks, Pancho. And you raise an important sort of concept, and one we've gone backwards and forwards. I guess on the one hand, these kinds of surveys are important because people may not want to be tested or receive their result. And it means if you require them to receive their result, you may get a biased sample. So it's the tension between an unbiased sample where you get a true reflection versus potentially a biased sample. But what you raise is an important, we need to make sure those services are still available in the best possible way. So I would say the only way you can ethically do sero surveys without giving results is if you're absolutely sure that those individuals still have access to getting tested voluntarily and getting their results in a very non-stigmatized, non-discriminatory way. And if that isn't available, then I think you need to question the individuals who are doing the sero surveys and make sure that they've thought that through. As I say, ideally in the world today, we wouldn't ever have anonymous surveys, but I do see the power of them in terms of giving us the information we need to know how the epidemic is going. I think this is probably the shortest answer I can give you, although I think it's a very long discussion we can have on another occasion because it has tension within it.
Thank you, Prof. And maybe one final one before we close up. Hilton Humphreys asks, in your opinion, what are some of the critical socio-behavioral issues that remain to be answered and that will be critical to think about in the next decade?
Yeah, I think, Hilton, I think some of them are the self-stigma aspect. So, I think we can try and reduce stigma in the community, but I think if individuals are really battling self-stigma, how do we overcome that? How do people develop that kind of, the kind of I guess, self-efficacy that Yvette's displayed beautifully today, you know, and others have been able to manage. Not everybody's able to do that, not only around their HIV status, but also sometimes about their sexuality or who they are, who they have sex with. All of that, you know, we need to find ways to reduce stigma that is external, but also help people overcome internal stigma, because I think that holds people back, and that's really very difficult. I think the second one that I would say is this notion of adherence, motivation for staying in care, on treatment, and that again applies to all of us, right? I am terrible about taking multivitamins. I'm terrible about adhering to any kind of, you know, daily intervention, and I can say that, you know, I'm willing to confess that. So I end up needing all kinds of assistance, like diaries and, you know, wonderful people in my life who help me remember things that are important. So that these are hard human behaviors that feed absolutely into our health behaviors as well. And so we need to find ways to improve all of that. I think those are my two main sort of human behaviors that I certainly battle with in my, you know, in my academic world, and I guess my personal world as well. But there may be others. That those are the two I would highlight right now.
Fantastic. So it seems we are landing just in time. So thank you, huge thank you to Professor Linda-Gail Bekker for just an excellent retrospective and ending on such a positive note, looking forward to the future ahead of World AIDS Day this year. So I'd like to thank everyone from our staff and our partners and just general audiences who have joined us today. And yeah, we look forward to many more discussions like this, and pop us your questions on Twitter. We'll continue the discussion there. Thank you, everyone. And thank you to Professor Linda-Gail Bekker.
Thanks, Emma.
Thank you.
Thanks, everyone. Take care.